Okay, this is going to be Critical Care Pharmacology Part 2, vasopressor agents. And vasopressor agents increase the afterload, blood pressure, and peripheral perfusion. Risk-benefit dilemma. Benefits, they increase blood pressure, they increase peripheral perfusion, which is a good thing. Risks, they increase myocardial workload. If the person got there from having an MI, we can make things actually worse, increase myocardial oxygen demand, and increase risk of ischemia. Vasopressors and sympathomimetics. Dopamine, hydrochloride, inotropin, or dopastat. Classification on this is going to be a sympathomimetic. It has both alpha and beta adrenergic agonist properties, which means it stimulates both the alpha and beta, which is essentially all of the sympathetic nervous system. Action exerts positive inotropic effects, imparts positive chronotropic effects, and then achieves peripheral vasoconstriction. And this is only at higher levels that we're going to see this. Indication: low perfusion or hypoperfusion secondary to a myocardial infarction, congestive heart failure, sepsis, neurologically induced vasodilation, so that's going to be like spinal cord trauma, and then renal failure. The renal dosing on this is a little lower, is at the very low end versus the vasopressor dose. Contraindications: hypovolemia. We should never try to give this in a hypovolemic shock scenario. Phenochromocystoma, which is a tumor on your adrenaline glands, which would kind of make things uncontrolled. Uncontrolled tachycardia. Ventricular irritability, so if they're having PVCs or runs of VTAC. Hypertension. Side effects on this: tachycardia, hypertension, ventricular irritability, angina, anxiety. Decreased peripheral perfusion. You can actually cause distal extremities in the vasopressor settings to become necrotic, tissue necrosis, extravasation, or if we get this medicine outside of the actual vein, that's going to be problematic. It works directly on the receptor site, so we're going to get that alpha response. This can cause tissue necrosis and necrosis of the tissues wherever it's outside of the vein. Dose on this, we're going to titrate to the effect. The first dose we're going to talk about is renal dosing, and this is still our dose times weight in kilograms times drip factor, which should be at 60, divided by our concentration strength. Now, concentration strength of single strength dopamine should be at 1600 mics per mil. So our first dose we're going to talk about here is 2 to 5 mics per kilogram per minute. Now that's going to be a renal artery dose that increases perfusion to the renal arteries. Next dose, 5 to 15 mics per kilogram per minute, is the cardiac dose. So we're going to get harder, faster, stronger out of this dosing. Vasopressor dose is going to be greater than 15 mics per kilogram per minute, and that's going to be the thing that gives us the alpha response. Pediatric dosing, titrate to effect, starting at 5 mics per kilogram per minute, and then we can kind of work our way up from there. The maximum amount that we're going to run into someone is going to be 20 mics per kilogram per minute. Special considerations: be alert for cardiac compromise. You may ask the patient more than they can actually give as far as their heart goes. Do not administer as an IV bolus. It's kind of uncontrolled. And ensure that there's IV patency. We do not want this to get outside of the tissues or get outside of the veins. Dobutamine hydrochloride, or Dobutrex. Classification: sympathomimetic, beta adrenergic agonist, and catecholamine. Actions: positive inotropic effect, and we get a very little amount of chronotropic effects, but it does give us a positive chronotropic effect as well. The Dobutrex, or Dobutamine, makes the heart beat harder, not specifically faster like dopamine would. Indications: congestive heart failure and decompensating cardiomyopathy, diseased heart. Contraindications: pre-existing hypertension, tachycardia, acute coronary syndrome with ventricular irritability, idiopathic hypertrophic subaortic stenosis. Any kind of aortic stenosis, we aren't going to want to increase contractile force strength of the heart. It's just not going to work the way we have planned. Known history of hypersensitivity to sympathomimetic amines. Side effects: tachycardia, hypertension, cardiac dysrhythmia, anginal pain, chest pain, anxiety, Decreased peripheral perfusion, tissue necrosis, and extravasation would not be good on this drug either. Dose on this is going to be 2 to 20 mics per kilogram per minute. Titrate to desired hemodynamic response, and remember we're going to use this to make increase contractile force strength. Special considerations: do not administer as an IV bolus and ensure IV patency. Phenylephrine, hydrochloride, or neosynephrine. Classification: sympathomimetic, mydriac, causes dilation of the pupils, and decongestion. Actions: elevates systolic and diastolic pressures, achieves venous and arterial vasoconstriction, and increases preload. And this is because it pretty much squeezes down the vessels. Big, gigantic alpha response with this medication. Indication: vascular shock. So anything to where the vessels, lumen, should be this, but they're like this instead. Anaphylaxis, sepsis, and neurogenic shock come to mind. Blood pressure maintenance during anesthesia also. Contraindications: coronary artery disease, hypertension, and ventricular tachycardia. Side effects: tachycardia, hypertension, ventricular irritability, angina or chest pain, anxiety, tissue necrosis, and extravasation would not be good on this here. This is going to work directly on the sites. If this gets outside of your veins, this is going to tell all of the alpha receptors to go ahead and constrict. This could cause tissue necrosis in the area where it's leaking. Dose on this is going to be 0.1 to 0.18 milligrams per minute until blood pressure stabilizes. Then we're going to initiate a maintenance infusion, 0.04 to 0.06 milligrams per minute maintenance infusion. Special considerations: use cautiously in patients with hyperthyroidism, diabetes, myocardial disease, cerebral arterial sclerosis, and bradycardia. Norepinephrine or Levophed or noradrenaline. Classification: sympathomimetic, alpha and beta adrenergic agonist. Actions: achieves alpha adrenergic stimulation, and this is pretty much again a big alpha drug or vasopressor. Imparts arterial and venous vasoconstriction, so this is going to constrict the entire vascular system. Indications: septic shock, hypotension associated with sympathectomy, surgical removal of one of the adrenaline glands, spinal cord injury, to where we have the vascular beds below the spinal cord injury dilating out, and then acute poliomyelitis. Contraindications: hypertension and shock secondary to hypovolemia. It isn't going to do us a bit of good to shunt everything towards the core if there's no fluid to shunt. Side effects: decreased renal perfusion. We can actually cut off the artery feeding the kidneys. Tachycardia, hypertension, cardiac dysrhythmias from an increased afterload, decreased peripheral perfusion, tissue necrosis, and then extravasation. This is going to be in the perfect form. It will act directly onto the receptor sites wherever it is leaking. Dose on this is going to be 0.5 to 1 microgram per minute. Titrate up to 30 mics per minute is needed to achieve desired hemodynamic effects. Typical therapeutic doses range from about 8 to 12 mics per minute. Special considerations on this: monitor the blood pressure and cardiac rhythm. Ensure that we have a patent IV, which is very, very important. Can cause tissue necrosis wherever it's leaking. Use cautiously in patients with hyperthyroidism or any type of heart disease. Epinephrine hydrochloride or adrenaline chloride. Classification on this is going to be a sympathomimetic. It gives us again both an alpha and a beta adrenergic response or stimulation, and it is also a bronchial dilator, really known for its big beta response. Epinephrine is. Action: alpha and beta adrenergic stimulation. Cardiac effects on this is going to increase chronotropy, which is rate, inotropy, which is contractile force strength, dromotropy, which is conduction velocity, peripheral vasoconstriction, which is a big alpha response, and the bronchial dilation is a beta 2 response. Indications: cardiac arrest, shock, bronchioconstriction, Contraindications: non-cardiac arrest patients, if they have hypertension, if they have tachycardia, any kind of acute coronary syndrome, narrow angle glaucoma, this isn't going to go well, probably going to cause some blindness, or advanced age. You can expect a 70-year-old to take a dose of rocket fuel. They are not going to do well. Their heart isn't going to be able to keep up. You can infarct them. No contraindications in cardiac arrest, though. We need to kind of kick things up a notch whenever they're in arrest. Side effects on this: tachycardia, hypertension, palpitations, cardiac dysrhythmias, tissue necrosis with infiltration, and this is if it gets outside of the vein, transient elevations in blood glucose levels, and this is because of fight or flight initiation. Dose of this in an anaphylaxis: 0.1 to 0.5 milligrams sub-Q, IV, or IM. Cardiac arrest rhythms, we're going to do a standard 1 milligram IV push every 35 minutes. If they're bradycardic, we're going to do 2 to 10 mics per minute in an infusion. Refractory hypotension, 1 to 4 mics per minute infusion, and titrate to desired effect. Pediatric, in anaphylaxis, 0.01 micrograms per kilogram, sub-Q, IM, or IV. Arrest rhythms, 0.01 milligrams per kilogram of 1 to 10,000, IV push every 3 to 5 minutes. Infusion, and this is if we're going to do an actual epi drip. Examples of this would be a little kiddo getting a hold of mom or dad's beta blocker, and for them that would be a beta blocker overdose. Infusion would be 0.1 to 1 mic per minute infusion. The antidote for the beta blocker would be glucagon, but we may actually have to start a supplemental epi drip to get past the cardiac compromise that the beta blocker has caused. Special considerations: monitor blood pressure and cardiac rhythm, and protect from light. Vasopressin injection. Pitressin. Classification: it's a hormone antidiuretic. Vasopressin is antidiuretic hormone, actually. Action: exhibits ADH properties, constricts vascular smooth muscle, and elevates systemic vascular resistance. So this is going to increase the vascular response throughout the body. Indication: diabetes insipidus. The people with diabetes insipidus will essentially, they have no ADH hormone, so they have they will urinate essentially their life away, causes massive dehydration. Polyuria secondary to ADH insufficiency. Cardiac arrest, this is also can be used as a bolus instead of epinephrine, or used as an alternate to epinephrine in the first 10 minutes. And then vasodilatory shock, neurogenic, septicemic, anaphylactic, distributive shock problems. Contraindications: known hypersensitivity, chronic nephritis or inflammation of the kidneys, advanced arteriosclerosis, ischemic heart disease, no contraindications in cardiac arrest. Side effects: we can get some bronchoconstriction from this, pallor from decreasing the lumen size of the vessels, nausea, abdominal cramping, angina, chest pain, hypertension, dysrhythmia from increasing afterload pressure or putting more workload on the heart, and respiratory congestion. Dose, non-arrest, 10 units IV push, and this would be for your insufficiencies and your diabetes insipidus. And in cardiac arrest, it's a 40 unit IV push, only utilized in the first 10 minutes. After that, we'll supplement with epinephrine. Special considerations: do not use with epinephrine. Only after the half-life or the actions of this drug has decreased. And in cardiac arrest, we will use it with epinephrine, but it will come 10 minutes down the road. Use cautiously in patients with coronary artery disease, pregnancy, epilepsy, asthma, and heart failure. This ends part 2. If you have any questions, feel free to contact me. My name is Roy Smith. Roy.Smith@redlandcc.edu or smithr@emsa.net. Thank you.